All right, I am here with Caryn Anthony. Thank you so much, Caryn, for taking some time to chat with me today. Would you like to take a moment to introduce yourself?
Sure. Thank you for inviting me, Lindsay. I'm Caryn Anthony, and I am a member of the Patient and Family Advisory Council at Children's National Hospital in Washington, D.C. I've been with that for about 7 years, and I've also been a family caregiver.
Wonderful. Thanks, Caryn. And so Caryn had joined a recent PFA Network coffee chat and shared a lot of new ideas and brought light to the issue of workforce safety from the patient and family caregiver perspective. So Caryn just wanted to revisit some of those discussions that we did have and would love to know what have you seen from your hospital or other hospitals or health systems as, prevention programs that are in place? What does that currently look like from your perspective?
There's been a few things that I've seen. The most concrete is at the security level, where we have the electronic gates that you come through that identify whether someone's carrying a weapon. And those were put up in a couple of entry points in the hospital. I thought they did a good job with that in testing it, in giving advance notice to folks that were coming in and helping, because it's based on, as I understand it, kind of an AI functionality. It needs to learn what's a stroller going to be, what's an umbrella going to be, what is a wheelchair going to be. But it gave people a chance to get used to this idea, and it was not meant to be, we're on the lookout for bad guys. It was, we want to keep everybody safe by making sure that inappropriate things don't come into the building. So they added that. There was some signage that was also added, and that came before PFAC when it was being considered. And there was a range of different ways of looking at how the message came across. And the messaging was meant to be, there are things you're not supposed to do or bring or have when you're in the doors here. And so one kind of stream of thought was no weapons, no drugs, no inappropriate content, that sort of thing. And PFAC really looked at that and said, it feels very negative. I can't say everybody agreed that that wasn't their favorite idea, but I think we went with a more help us keep a healing place
Mhm.
sort of messaging with that. And we can talk more about why and how the differences in opinion were. And then the other thing that was done was adding some new practice to respond to a crisis situation. Who comes, under what circumstances, and what training have they been given or do they have to help manage a volatile situation? So that sort of de-escalation and who's bringing more people involved kind of thing. So that's become more widespread.
Great, thank you. And let's talk about the signage and the process for, bringing in the perspectives of patients and families into that type of messaging. And just would love to hear your thoughts around, signage in general and, where can we dive a little bit deeper into looking at workforce safety?
So I appreciate that anybody's going to bring signage to us in the first place, because
Mhm.
that's always, because the family and patients are the readers of the signs. That's who they're intended for. So you definitely want to have them looking at what the draft language is to say, how do you react to this? Do you understand it? Does it bring up questions that are not answered sufficiently? Does it bring up um, uh, a feeling or a message that maybe wasn't intended? So that's, first of all, I think it should happen. Um, there were some people who looked at signage that was more about obstacles and limits and said, this makes me feel safer. They said, I found this in the community. I've been to other maybe government offices, and it says this behavior is unacceptable and will escort you out if you do that. And some people really like that idea of saying, this is the boundaries, and it makes it clear. I think also that I've seen some feedback that some staff look at that and say, I feel better knowing that this policy, like there's a policy here, and it's very clear, and no one can say, you didn't tell me I couldn't do that. So it does send a message to the environment that these are not tolerated acts and behaviors. I have a kind of a different perspective on that. I don't think that anybody who's going to be violent with staff is going to read a sign and say, oh, I guess I shouldn't yell at the ER physician who's taking care of my child. I don't think the sign is going to prevent them from seeing that. I think that it creates a kind of punitive style of communication that is not what anybody wants in a healthcare environment. I think that some people also shared that reading signs like that in the hospital makes them worry and wonder, oh, does this happen here? Should I be worried about my own safety? Because we have to put up signs that say, watch out for the people who might do bad things. I'm not convinced that signage is really that much of an actual solution. If you want to say what you mean in some sort of values way, sure, but it's not going to prevent bad behavior. But punitive language is also not going to prevent bad behavior. I would rather see that impulse, which I agree with, of saying we don't want someone who's unsafe in this environment, but I'd rather see that energy put into someplace else. That is, I'm sorry this is my belief. I don't think a nurse is going to not get hit because someone read a sign that says don't hit the healthcare staff. I think that if someone's going to be violent, there are other ways to look out for the signs. There are other things, the signs, for the indicators that something might be happening. And I would rather see more of that. I think it's fine to say, help us keep a calm environment. I think that's great. But there are lots of things that keep a nice environment that have nothing to do with signage. So those would be the things that are my preference in that area.
Yeah, absolutely. And do you mind if we talk a little bit about the environment too? I think we've heard some examples of creating that type of calming environment. So we'd just love to hear your thoughts on kind of what that means to you.
It's a lot about having a holistic picture of the human beings who are walking in the door to get care for themselves or their family members. So they shouldn't feel like they're being herded. They shouldn't feel like they're being controlled, in a space that encloses them and keeps them locked up and away from something. They want to make them feel they've come there for a purpose in a bad moment in their life, and they want to feel cared for. They want to feel seen and heard. Something about the space should be comfortable to sit in. It should not be loud. It should be accessible to anybody who needs to come in there. So if you're coming in with a child, then we need to know that some of the space needs to be okay for a child to be in. And because if children are going to be there, they're going to be antsy and need to move around, and you're probably going to have a wait. It should be transparent to people who are coming in. So the ED is a big place where you see a lot of people walking in the door and having to deal with the environment. But this is true in any clinic setting. You want to know what's going to happen next. You want to know how long it's going to take. So transparency about that, even if it's not good news, is better than not telling anybody, because that's what frustrates people and makes them angry and makes them not be seen. I would say being greeted and have people use your name is a way to create an environment where it's respectful and understanding of who you are. So there's HIPAA rules about how you're supposed to call people's names out or not call people's names out. Don't assign a number. I'm not at the deli counter. And if I don't like, this is a personal preference of mine, I didn't like when staff called me mom. If you don't know my name, don't use my name. But I don't want to be called by this fake intimate title. Yeah. All of those things feel respectful of me as a caregiver and a family member and as a patient. Make the space accessible, make it feel like it's okay. Make sure you've sent the message with the physical space that we care about you. If you're sitting in uncomfortable chairs in a cold place with hard surfaces and there's no place to get a drink of water and ask a question and get to the restroom, you're going to feel not respected and not like people are taking seriously what's going on for you.
Yeah.
And the transparency of the information is really, really important. I will
Yeah.
say, having been to the ED a number of times with my son when he was ill, triage is the art form of the staff. And I absolutely understand, the more you go, that they take the most vulnerable, needy people first. But it stinks to be the person who's come there for strep throat and to sit around for hours and hours and hours and watch people come after you and go
Right.
right through the doors. So I think you need to set some expectations with that.
Mm.
That said, I've had other folks say to me, I'm sorry for your wait, but that's good because it means that it's not that emergent. And it's sort of, it strikes the wrong note. You know, I
Mm.
want you to acknowledge the trouble that I've gone to and the discomfort that we're in, but yes, I want you to tell me that we waited a long time, but I don't want you to say lucky me, not like this other
Right.
family that brought their kid right in, because that also doesn't feel good. Nobody who goes
Yeah.
straight through the doors feels like that's a lucky thing for them.
Right. No, that's a great point, and I love that you brought up transparency too, because yeah, I feel like just a lot of people are walking into this world of unknown, and that alone just causes a lot of anxiety and fear for what's about to happen. So I really appreciate that point about transparency.
And it's really
Um,
important for
yeah,
people who, I was a frequent flyer in the hospital, but people who are coming in for the first time, or they haven't come a lot, or they come from another country where the system works differently, they need expectations of what's going to happen first, second, and third. And you need to make sure that they understand it, because it's not everybody comes in with well, of course, this is how you check in with the reception person at the clinic, and then you sit down, and then they call you, and sometimes it goes, if you have sometimes your appointment time doesn't happen the way it's supposed to, but we need to make sure people understand all of that. And I don't know that
yeah.
everybody does understand that that's the way the system works.
Yeah, no, that's a great point, and I completely agree. Yeah, there's so much unknown in
Mhm.
healthcare, and I know, my friends, my husband, that they wouldn't know what they're walking into half the time. So I can imagine that would be extremely beneficial, that just knowing what's going to happen and when. Um, I wanted to go back to your comment about who is responding to incidences of violence when they do occur. It sounded like that was something that came up in the advisory council. Would love to hear your thoughts on that, and also how bias plays um, into violent incidences and this whole topic of workforce safety.
Yeah. So one of the things that was really important is to figure out a way to respond to a potentially volatile situation with somebody other than just security. Um, and that's to make security's job easier. That's to make sure that we can take care of whatever need is bubbling up in that. Um, and I'd like to see that I'd like to think that security is getting training on de-escalating a situation for sure. Um, but sometimes that meant social worker or a chaplain, or maybe it means, oh, your child's in there for days on end, and maybe it's just the nurse who knows your family. But having a practice of making the personal connection for this person who is having a difficult time.
Yeah.
And bias comes in with the idea of who needs to have this call made,
Mhm.
because someone in one circumstance, one person may say, Caryn is angry and frustrated because her kid has been inpatient for the last 24 hours and isn't allowed to eat or drink until something's going to happen. And she's agitated because this has gone on a long time. And some people are going to say, well, that's just an agitated parent who's looking out for her kid. And somebody else might say, she's being threatening. Her anger seems out of control to me. You don't know how people are perceiving this. And there's plenty of research and life experience out in the world that says some people find other people in different circumstances that are different than them to be more or less relatable. And the less relatable they are, the more likely they are to say, I don't know what I'm going to do with this person. I can't figure this out. I'm just going to call security because I don't want this to go off the rails.
Right.
But that means that it gets applied in a rather subjective way and can be applied quite unfairly. And I've heard lots and lots of stories of people just moving through their lives that are already very difficult because I come through a pediatric hospital, because their child is in the hospital. They're already in a crisis place.
Yeah.
But then to have other things thrown in. One person I know whose 14-year-old son was stopped several days in a row walking from the cafeteria back to his siblings' room by, what are you doing here? Why aren't you, do you have the right to be here? And it just felt like harassment because somebody looked at this 14-year-old boy and decided that he didn't look like someone who belonged to be there. Or I've definitely heard stories from other parents who got into an angry argument with someone on staff, and it became the staff member didn't want to deal, and it turned into, okay, well, we're going to get security to do this. Or you come up with a behavior modification plan for someone who was really just very frustrated because it was the fifth problem that had come up and people were not giving them a straight answer, and now the parent is being seen as a problem. Right. Rather than the family needs to be taken care of, and what can we do to deal with that? There was a time when my son was being treated at the hospital where he got really bad news that was very unexpected. And he was at the time 19. And the team left the room. I was in the room with him and the nurse, and he started knocking stuff down and throwing things. And he was just in full rage response, which made a lot of sense given what he had heard. But we all left the room, shut the door, gave him privacy, gave him a chance to cool down. He didn't break anything expensive. I guess that could have happened, but no one called security on him. Nobody said, here's a 19-year-old young man who is damaging property and is a danger to staff. They understood that this was going on. They gave him a few minutes to chill out, and then they figured out a way to come in there. Yeah. I don't know that everybody would have gotten the same grace in that situation.
Yeah. I think that's such a great example too of, you as your son's mom and knowing him so well, knowing that he needs a few minutes to, just let this out. This is hard to go through, to be able to work with, nursing staff, or having the nursing staff or physician, whoever was there, understand that this time was needed and be able to work with you to take that time away. That's just such a great example. And I wanted to ask, even further, how do we make sure that the family caregiver and the patient voices are heard and they're invited in and they're a part of, none of us want to see violence happening in healthcare or anywhere else. We're all in this together. So how do we do that?
I have so much profound respect and gratitude for the healthcare staff and the just hospital staff, the EVS workers and the cafeteria workers and the parking guys. They did so much to make my family's life better when we were going through this. And of course, they deserve to have a safe environment, and no one should be behaving inappropriately or violently in any way, shape, or form. And my son's behavior was inappropriate, but we did, it was not the right, but we gave the grace to say that sometimes you need to let him have his feelings, and he's not going to sit there with his hands folded in his lap. And as long as he's not hurting himself or anybody else or doing any real damage, but knocking over an IV pole and flipping over a chair, that's probably an okay thing to do. How you have the family voice it needs to be integral in multiple layers of what's going on within the system. It needs to be, I'm a big believer, obviously, in the Patient and Family Advisory Council, and there are patient advisory councils by specialty area, or also We have ones like we have one for global services, we have ones for different locations and things. And that's a great way to understand what is going on from that perspective. You know, what's it like in BMT, or what's it like in the CCU or the ED or anything like that. But also it's really excellent to have a family member or a patient, if you can, be part of committees of the hospital that are looking at policy and practice. So I know that I sat on the Patient Experience Steering Committee when I was chair of PFAC, and that was really valuable because they're looking at patient experience feedback, and I could talk to what was it like to be the person who wrote the survey that gave those survey responses, or what that was like.
Right.
There's a colleague and friend of mine who's on the patient-facing technology committee, to say, what's it like to use the portal? I know someone who's on the pain management committee, having folks with lived experience, not that they're the only, obviously they're not the only experts in the room, but having them part of the conversation is really, really integral. At Children's, the PFAC that I'm on, I'm really proud to say we're going to be doing our third grand rounds this year. We've done them the last couple of years, and that's saying we believe that what PFAC has to offer is at the same level of importance in medical education as someone who wants to learn about a new procedure or a new drug or a new public health trend or whatever else that they want to teach. PFAC has something, is a partner in that way. And that's really powerful to do that. It has to be built into the culture in that way, and not just in the, let's hear the inspiring story of the patient journey.
Right.
That's nice. And I'm glad people learn about that, but that's insufficient. Really need to get deeper into the works for it to be really valuable.
Yeah, 100%. Yeah, there's so much value in patient family advisory councils. And, we've been talking about lanes of engagement for patient family partners.
Right.
And, can you survey and say, help us create a healing environment? What does that look like to you?
Right.
Quick little touch points. So I think there's, yeah, so many ways to really embed, the voice, the perspectives and experiences of patients and family caregivers in improvement
I think
work.
it's also really important to know that everybody who touches a patient and family is not just healthcare providers,
Yeah,
right?
yeah,
So you want to be infusing that perspective
yeah,
with everybody, with the billing people, with the cafeteria people, with all of those people, because anybody who's been in that space knows that the guy that greets you when you come to park your car in the morning
right.
and says hello like he has seen you every day makes you feel good. That's really powerful for having a family voice, and makes me feel like I'm coming to a safe place because people here
Right.
care about me,
Yeah,
and people.
it's setting you up. Yeah, yeah.
Yeah, yeah.
Amazing. Well, so Caryn, I meant to ask you this in the beginning of our discussion, but I was just so excited to hear what you had to say. To wrap us up, I just want to know why this is so important to you and important for us to be talking about in the webinar, and just important for all of us to keep top of mind and consider as far as workforce safety. I mean, we're obviously promoting patient family engagement practices within developing those programs and policies, but want to know why this is so important to you, and then anything else you'd like to share to wrap us up.
Um, the workforce in healthcare is precious and stressed. And that's the reason I want them to feel safe, and I want them to feel seen and heard and cared for. We need them. And we learned that the hard way during COVID. And the folks who are still there have been through quite an ordeal. And I have so much gratitude for the work that they continue to do to stay in it, even when budgets are cut and staff is short. So I want them to be there and to feel like this is that they are fulfilling the work that they chose to do on purpose. That no one who comes into this field does it because, well, it's a fine job. They do it because they want to help people. So you want to nurture that and support that. And safety is the way that you do that. But I want safety to come from a place of what we're really doing actually makes people safer,
Mm.
and does it in a way that looks at safety of everybody. Because if we get into a punitive framework for that, then I worry that families and patients are not, their safety is also at stake in some of this. If we're trying to control things too much, and we worry it's too subjective, it's not consistent, it makes we miss out on on serving as many people as possible and including as many ideas and perspectives as possible. So yes, we should make sure that no one is going through something where they feel like their patients or family members are abusing staff. That's terrible, and it's unacceptable. And we shouldn't make someone be judged and harmed and punished for the worst thing they do on a terrible day for themselves and their family. Everybody's not at their best when they've taken their child or their beloved family member to a hospital or even just to the doctor to handle a problem. So we want to do that with the most compassion possible and be safe. And I think we can do both. I don't think you need to say, one strike and you're out. If you yell at the person, you can't come back in the building, because I don't think that serves anybody. I think there are better ways to serve that.
Yeah, absolutely. Well, thank you so much, Caryn. Was there anything else that you would like to share?
Just a big thank you to everybody who does this work and works on this perspective of engaging family members. I'm grateful for it. I'm passionate about it. And I think it really matters in the way that dynamic happens and what happens for patients and how the community serves what they're trying to do in the first place. So thank you.